Imagine you are working the evening shift in the lab and a frantic call comes in from the ER. They have a 65-year-old patient who just rolled in. You ran the chemistry panel and the sodium result flashing on your screen is 118 millimoles per liter.
Right, which is critically low. I mean, physiologically, a patient with a sodium of 118 should be seizing, slipping into a coma, or showing massive neurological deficits.
Exactly. But the ER doc on the phone is completely confused, telling you the patient is sitting up in bed, fully awake, chatting about the weather, and asking for a turkey sandwich. The doctor is panicking, wondering if the patient is about to crash.
Yeah, but here is the secret that separates a seasoned tech from a novice. The patient isn't crashing. The machine is lying to you.
And knowing exactly how and why that machine is lying is the entire difference between passing and failing the ASCP MLS board exam. That scenario is, one of the most classic diagnostic traps in clinical chemistry.
Oh, absolutely. You are in the final stretch now. The flashcards are done, the endless textbook chapters are behind you, and you already know the basic definitions. If you're listening to this deep dive, you know what a spectrophotometer is, and you know what the kidneys do.
Right. Our mission today is to execute a high-density, final stretch technical briefing. We're going to dissect the physical mechanisms behind these specific board-level rationales, exposing the diagnostic patterns that dictate patient care.
We are attacking the distractors, we are mapping the formulas to rapid mental math, and we are identifying the critical traps the exam writers use to catch you off guard. Because knowing the correct answer is, it's really only half the battle.
Exactly. You have to look at the 4 options on the screen and know exactly why the other 3 are factually true statements that just happen to be completely irrelevant to the physiological failure presented in the question.
So we're going to look at the entire analytical spectrum today. We'll start with the raw physics of the instrumentation, work our way through the chemical gradients of the blood, explore major organ systems, and finally tie it all together in massive, multi-organ cascading failures.
Because we need to trust the physics of the measurement before we can ever trust a patient result. So let's start right there, at the foundational physics of the lab. Every single tech relies on Beer's law, but the exam wants you to manipulate it practically.
Yeah, the literal formula you need to visualize is absolute. Absorbance equals 2 minus the log of percent transmittance. That is, A equals 2 minus log percent T.
And you won't have a graphing calculator on the exam, which means you have to rely on mental math. The exam writers want to see if you intuitively understand the inverse logarithmic relationship that forms the foundation of photometric chemistry.
Right. So if a question states that the percent transmittance, the percent T of a solution is 10.0, you don't need to panic. You just take the base 10 logarithm of 10, which is exactly 1.0.
Then you plug that back into the formula. Absorbance equals 2 minus 1.0. So your absorbance is 1.0. It's an elegant, rapid calculation that you should be able to do in 5 seconds.
And if you have a perfectly clear blank solution where the percent T is 100, the log of 100 is 2. Therefore, A equals 2 minus 2, which equals 0 absorbance.
But what gets tricky is when they test the relationship variables within Beer's law. Let's look at the expanded formula. Absorbance equals A times B times C.
Right, where A is the absorptivity coefficient of the specific molecule, B is the path length of the light through the cuvette, and C is the concentration of the molecule.
A classic board distractor will present a scenario where the path length of the cuvette is doubled and ask what happens to the absorbance. You have to think about the physical geometry happening inside that little plastic box.
If you stretch that cuvette and make the light travel through twice the distance of fluid, that beam of light is going to physically bump into twice the number of target molecules.
Exactly. That increased molecular crowding has the exact same mathematical effect as keeping the cuvette the exact same size, but doubling the concentration of the molecules inside it. So doubling the path length doubles the absorbance.
But that perfect mathematical relationship assumes your optical system is flawless. And, in the real world, it never is. This brings us to a massive point of vulnerability, which is stray light.
Stray light is any photon hitting your photomultiplier tube that is outside the specific narrow wavelength you are trying to measure. It usually leaks in from deteriorated optics, a darkened envelope around your halogen lamp, or just room light bleeding through a degraded seal.
So think about this practically. If stray light is just a little bit of extra light hitting the detector, why does it specifically destroy the linearity of your assay at the high end of the concentration curve?
Wait, yeah, why wouldn't it ruin a low concentration sample just as much?
It comes down to percentages and the concept of signal-to-noise ratio. Imagine a highly concentrated patient sample. It's a very dark solution. Because the concentration is so high, the absorption is immense, meaning the actual transmitted light successfully reaching the detector is at its absolute lowest.
Right, so let's say only 1% of the original light is supposed to make it through. If your machine has a tiny leak and 2% stray light sneaks around the cuvette and hits the detector, your detector now registers 3% total light.
Exactly. You have just artificially tripled your signal. The machine thinks the sample is much lighter, and therefore much less concentrated than it actually is. Your linear curve suddenly flattens out at the top.
But if you have a low concentration sample where 90% of the light is naturally transmitted, adding that same 2% stray light brings the total to 92%. It's a drop in the bucket. The error is negligible.
Right, so stray light is a high concentration killer. And the distractors on the exam will try to trick you on how to fix this. An option might say that stray light is corrected or detected by performing a wavelength calibration using holmium oxide glass.
Do not fall for it. The ASCP board trap right there is confusing wavelength accuracy with stray light. Holmium oxide glass has these beautifully sharp, narrow absorbance peaks, which makes it perfect for verifying wavelength accuracy.
Making sure 450 nanometers is actually 450 nanometers, right? But stray light is an entirely different physical problem, and it is detected using sharp cutoff filters. A sharp cutoff filter is, well, exactly what it sounds like.
It transmits almost all incident light perfectly until it hits a specific, sudden cutoff wavelength, at which point it acts like a brick wall and transmits absolute zero.
So if you place a cutoff filter in the path, set the instrument past that cutoff wavelength, and the detector registers any light at all, you know definitively that light is sneaking in from somewhere else. That is stray light.
While we are looking at the purity of a light beam, we also have to discuss bandpass. The bandpass is the actual range of wavelengths passing through the exit slit of your monochromator. It's not just a single pure photon, it's a little cluster of wavelengths.
And the golden rule for accurate absorbance measurements is that your instrument's bandpass must be less than 1/5 of the natural bandpass of the chromophore you are trying to measure.
If the exit slit is too wide, you lose photometric resolution and your peaks will blur together, compromising the sensitivity of the entire assay. But if you really want to talk about sensitivity, we have to move past standard spectrophotometry and look at fluorometry.
The fundamental distinction here is that fluorometry is vastly more sensitive and significantly more specific. And the specificity comes from its architecture. It utilizes dual monochromators.
You have a primary monochromator to isolate the exact excitation wavelength hitting the patient sample. Then, place at a 90-degree right angle, you have a secondary monochromator to isolate the distinct emission wavelength coming off the fluorescent molecules.
But why does that make it more sensitive? Because you are measuring emitted light against absolute darkness. In standard spectrophotometry, you are looking for a tiny decrease in a very bright light.
Like trying to spot a missing headlight in oncoming traffic.
Exactly. But in fluorometry, the right angle detector means the bright excitation beam passes straight by. The detector only sees the photons emitted by the glowing sample against a pitch black background.
Because the background is zero, you can electronically amplify the detector signal massively without amplifying any source noise. But that incredible sensitivity comes with profound environmental vulnerabilities.
The primary interference you will be tested on is the inverse relationship between fluorescence and temperature. Think about fluorescence on a molecular level. A molecule absorbs a photon, an electron jumps up to an excited energy state, and when it drops back down, it spits out a new photon of light.
That is fluorescence. But as the temperature of your reaction environment increases, the physical kinetic energy in the fluid increases. The molecules start bouncing around like crazy.
Right, so instead of the excited electron dropping back down naturally and emitting a photon, the excited molecule collides violently with another molecule. The excitation energy gets transferred and dissipated as plain old heat rather than light.
So as temperature goes up, fluorescence drastically goes down. If your lab's air conditioning fails, your fluorometry assays will systematically drift low. We see a similar reliance on physical angles when we talk about nephelometry.
Yeah, nephelometry measures light scattered by particulate complexes. Usually, we're talking about antigen-antibody lattices floating in the cuvette. The physical rule governing this is Rayleigh's law,
which dictates that when the incident wavelength of the light is much longer than the physical diameter of the particles, you achieve maximum backscatter. But the exam will target the hardware setup. A lot of people confuse turbidimetry with nephelometry.
In turbidimetry, the detector is placed 180 degrees from the light source, directly behind the cuvette, to measure the decrease in transmitted light caused by the cloudy sample. Nephelometry is entirely different.
It places the detector at an angle, usually somewhere between 25 and 90 degrees. This off-angle placement means it isn't measuring what passes through, it is measuring the light that physically bounces off the particles toward the side.
Because of this, the detector output in nephelometry is directly, rather than inversely, proportional to the concentration of the scattering particles. More particles equals more scatter, which equals higher signal.
Understanding how molecules move and interact physically is the perfect bridge into our final physical separation technique, electrophoresis. In clinical chemistry, this almost always involves serum protein electrophoresis.
You absolutely must understand the behavior of proteins in an electric field based on their isoelectric point, or PI. The standard buffer used in the lab for SPEP is set to a highly specific pH of 8.6.
Why 8.6? Because at that alkaline pH, almost all of your major serum proteins are in an environment that is significantly higher than their respective isoelectric points.
And when the environmental pH is higher than a protein's PI, the protein acts as an acid. It gives up protons to the buffer and takes on a net negative charge, becomes an anion.
And because it is negatively charged, when you apply the voltage, it naturally migrates toward the positive electrode, the anode. The speed of that migration is a massive exam target.
Right. Albumin is the fastest migrating protein on the gel. Why? Because it has an exceptionally low PI, right around 4.6. The difference between its PI of 4.6 and the buffer's pH of 8.6 is huge.
This massive gap gives albumin an incredibly strong, dense negative charge, so it literally races toward the anode, leaving the other proteins behind. But here's the critical trap that distractors will lay for you.
Gamma globulins, which are primarily your IgG antibodies, have a relatively high PI, hovering right around 7.2. Because 7.2 is fairly close to 8.6, they have a very weak negative charge.
You would logically expect them to just sluggishly slide forward a few millimeters and sit near the application point. But if you look at a stained gel, the gamma globulins actually migrate backward toward the negative cathode.
The distractors will give you an option claiming this is because IgG has a net positive charge at pH 8.6. That is a lie. They are negatively charged, but they are pushed backward by a physical phenomenon called electroendosmosis.
Electroendosmosis is an incredible physical matrix effect. Let's visualize the support medium, typically an agarose gel. The agarose itself isn't completely neutral. It has a fixed matrix of negative charges.
When you flood that gel with the pH 8.6 buffer and flip on the power, the positive ions floating freely within the buffer naturally cloud around those fixed negative sites on the agarose.
When the voltage hits, those positive buffer ions surge powerfully toward the negative cathode. They drag the water molecules with them. This creates a literal microscopic river of buffer flowing backward through the gel.
And the gamma globulins have such a weak negative charge pulling them forward that they cannot swim upstream against this rushing river. They are physically swept backward toward the cathode by the wick flow of the buffer itself.
It is entirely a matrix flow issue, not a charge reversal, which is a brilliant transition. We just looked at how pH and charge dictate the physical flow of proteins across a gel. Now let's dive into how the body manages those exact same chemical charges and pH levels within the flowing matrix of the blood itself.
We have to talk about blood gases and electrolytes. And you cannot discuss blood pH without invoking the Henderson-Hasselbalch equation and the physiological buffer systems. You need to know the hierarchy of these systems.
If you rank the primary blood buffer bases in descending order of concentration, you start with bicarbonate, followed by deoxyhemoglobin, then albumin, and finally monohydrogen phosphate.
Bicarbonate is the undisputed king of the extracellular fluid. The formula rule for the Henderson-Hasselbalch equation allows us to compute the exact pH of the blood based entirely on the ratio of that primary buffer system.
The formula is pH equals the pKa plus the log of the concentration of bicarbonate divided by the concentration of dissolved carbon dioxide. That ratio is normally exactly 20:1, 20 parts bicarbonate base to 1 part dissolved CO2 acid.
But you might wonder why we only calculate this one system when there are 3 others actively working in the blood. It comes down to a physiological concept called the isohydric principle.
Because all the blood buffer systems share the exact same fluid compartment and are all simultaneously reacting to the same hydrogen ion concentration, they are all locked in dynamic equilibrium with each other. By meticulously measuring the bicarbonate system, we instantly know the status of all the others.
Let's look a little closer at the bottom of that buffer hierarchy list, specifically the phosphate buffer. monohydrogen phosphate. In every other physiological context, phosphate is overwhelmingly taught as an intracellular ion.
Wait, right, it lives inside the cells, driving ATP synthesis. So how does it suddenly act as a highly efficient primary buffer out in the extracellular blood plasma where its concentration is relatively low?
It achieves incredible efficiency entirely because of its specific pKa in relation to normal physiological pH. At a healthy blood pH of 7.4, the chemical equilibrium of the phosphate buffer system shifts.
The ratio of the weak acid form, which is H2KO4-1, to its conjugate base form, HPO4-2, is highly unbalanced. There is significantly more of the weak acid form present.
Because there is this massive, ready reservoir of the acid form floating in the plasma, the phosphate buffer system is aggressively primed to neutralize any incoming base. This makes it incredibly effective at preventing sudden shifts into alkalosis.
But the exam isn't going to test you on a healthy patient. They will test you on the extreme failures of these systems, specifically metabolic acidosis and the devastating lactate pathways. Everyone knows that severe tissue hypoxia causes lactic acidosis.
Right, the patient stops breathing, oxygen drops, lactate spikes. But the board questions will dig deeper. They want to know the exact intracellular biochemical mechanism. Why does the absence of oxygen force the creation of lactic acid?
We have to step inside the cell and look at the mitochondria. Under hypoxic conditions, the electron transport chain, which requires oxygen as its final electron acceptor, completely stalls out. It backs up like a traffic jam.
Because the chain is stalled, the cell rapidly burns through its available supply of NAD plus wood, converting it all to NADH. The problem is that NAD plus is an absolute, non-negotiable requirement for glycolysis.
Without oxygen, glycolysis is the only remaining pathway keeping the cell alive and generating minimal ATP. To keep glycolysis running, the cell desperately needs to regenerate NAD plus bit.
It achieves this survival mechanism through the enzyme lactate dehydrogenase. The cell takes pyruvate, the end product of glycolysis, and forcibly reduces it to lactate. That specific chemical reduction reaction consumes NADH and regenerates the precious NAD plus needed to keep the lights on.
It saves the cell from immediate death, but the catastrophic side effect is that it floods the surrounding blood plasma with massive amounts of lactic acid, dropping the pH and initiating severe metabolic acidosis.
And once that metabolic acidosis sets in, the body's compensatory mechanisms kick into overdrive. The primary mechanism of compensation for metabolic acidosis is respiratory.
The peripheral chemoreceptors in the carotid bodies and aortic arch detect the sudden drop in blood pH. They instantly send distress signals to the respiratory center in the brainstem, which triggers hyperventilation.
You will see the patient start taking these rapid, incredibly deep breaths, classic Kussmaul respirations. The physical goal is to blow off massive amounts of CO2 gas from the lungs. Let's bring this back to the Henderson-Hasselbalch equation.
The numerator, the bicarbonate, has plummeted because it was consumed buffering the lactic acid. To maintain that crucial 20-to-1 ratio, the lungs aggressively blow off the denominator, the dissolved CO2.
The body sacrifices total volume to restore the ratio, stabilizing the pH until the underlying hypoxia can be reversed. And while we are measuring the gases and buffers in the plasma, we also have to account for the physical solute load suspended within it.
You must know how to calculate plasma osmolality rapidly. The formula rule you need locked in your brain is 2 times sodium plus glucose divided by 18 plus BUN divided by 2.8.
The mental math logic behind this formula is crucial so you don't second-guess yourself under exam pressure. Why do we multiply sodium by 2? Because sodium is the dominant extracellular cetation, but it never travels alone.
It always physically associates with a counter-ion, primarily chloride, or bicarbonate, to maintain electrical neutrality in the fluid. So instead of measuring all three separately, multiplying the sodium value by 2 provides a highly accurate estimate of the total millimoles per liter of all the major electrolytes combined.
Now, what about the divisions? The lab measures glucose and BUN in milligrams per deciliter, which is a measure of mass. But osmolality doesn't care about mass. It cares about the absolute number of physical particles exerting osmotic pressure.
Dividing glucose by its molecular weight factor of 18 and BUN by its factor of 2.8 converts their mass units into millimoles per liter. This harmonizes the units across the board, allowing you to add the electrolytes, the sugar, and the urea together to find the total osmotic pull of the patient's plasma.
Which brings us perfectly back to the scenario we opened the show with. The pseudo-hyponatremia trap. Let's revisit that patient in the ER. They have severely lipemic serum, or maybe their triglycerides are over 2,000.
Or they have a massive spike in monoclonal protein from multiple myeloma. You run the basic metabolic panel, and the sodium comes back at a terrifying 118 millimole. The patient is totally asymptomatic.
The ASCP board trap is believing the result on the screen. If your lab uses an indirect ion selective electrode, or indirect IS, that critically low result is a physically induced machine error. It is not a physiological failure of the patient.
We have to understand the microplumbing of the analyzer. An indirect IS is designed for high-throughput testing, which means it requires a dilution step before the sample ever touches the measuring electrode.
In a normal healthy patient, blood plasma is about 93% liquid water and 7% solid space taken up by lipids and proteins. Sodium, being a water-soluble ion, only exists in that 93% water phase. There is zero sodium hiding inside a lipid molecule.
Now imagine our severely lipemic patient. Their lipid levels are so incredibly massive that the solid phase physically expands to take up 20% of the sample tube, leaving only 80% as actual plasma water.
The instrument's pipetter drops in, assumes the sample is normal, and grabs a fixed microliter volume of that serum. But because those massive lipid globules physically displaced the water, the pipetter grabbed far less actual plasma water.
And therefore, a drastically lower mass of actual sodium ions than it was programmed to assume. When that deficient microsample is diluted with a massive volume of buffer and finally measured by the electrode, the calculated final sodium concentration is artificially plummeted. The machine mathematically multiplies a physical lie.
And how do you prove it's a lie? You take that exact same tube of blood and you run it on a blood gas analyzer that utilizes a direct ion selective electrode.
Direct IOSs do not perform any dilution. They expose the whole blood or undiluted plasma directly to the surface of the electrode membrane. Because there is no dilution step making mathematical assumptions about water volume, a direct ISIA measures the actual physiological activity of the sodium ions in the water phase that is present.
It is completely 100% unaffected by the lipid or protein matrix. The direct ISE will give you the true sodium value of 140 millimole, saving the patient from an unnecessary and potentially lethal saline infusion.
That is exactly why understanding the physical matrix of the plasma is non-negotiable. Speaking of dilutional errors and suspended solutes, let's look at the specific analytes floating in that plasma, starting with our primary energy and oxygen carriers.
We are diving into glucose, hemoglobin, iron, and bilirubin. For glucose measurement, the exam wants you to rank the testing methodologies. Hexokinase is the undisputed reference method.
It is vastly superior in accuracy because the primary phosphorylation step is tightly coupled with glucose 6-phosphate dehydrogenase, or G6PD. This specific enzymatic cascade is highly immune to interference.
But hexokinase reagents are expensive, so the routine workhorse in thousands of labs across the country is the cheaper glucose oxidase method. And if a method is cheap and routine, you know the board is going to heavily test its vulnerabilities.
The specific negative interference of the glucose oxidase method is a high-yield topic. The primary oxidase enzyme itself is remarkably specific. It only reacts with beta-D-glucose. The problem lies entirely in the secondary step.
To actually measure the reaction, the method relies on a peroxidase coupling reaction that takes the hydrogen peroxide generated in step 1 and uses it to oxidize a chromogen, producing a color change. The machine measures the color.
But if the patient's blood is loaded with strong reducing agents, classic culprits being extremely high levels of ascorbic acid, which is vitamin C, or massively elevated uric acid, those reducing agents will actively compete with your assay's chromogen for that hydrogen peroxide.
They act like chemical sponges. If the ascorbate steals the peroxide, the chromogen never gets oxidized, the color never forms, and the photometer reports a falsely lowered, potentially hypoglycemic glucose level.
Moving from acute glucose measurement to long-term diabetes monitoring, you have to know the ADA diagnostic cutoffs, specifically regarding microalbuminuria. Microalbuminuria is the very first clinical signal of the onset of diabetic nephropathy.
The delicate filtration barrier in the glomerulus is starting to break down from chronic hyperglycemia. The absolute diagnostic cutoff is an excretion of greater than or equal to 30 milligrams per gram of creatinine, but strictly less than or equal to 299 milligrams per gram.
The moment it hits 300, you have crossed the threshold into clinical gross proteinuria. The classic distractor on the exam involves how you collect the specimen. The options will present a 24-hour timed urine collection as the gold standard for accuracy. Do not select it.
While a 24-hour collection sounds mathematically superior, it is practically disastrous. Patients routinely forget to collect a void, or they undercollect, invalidating the entire mass calculation.
The clinically preferred and widely tested standard is measuring a random spot urine albumin to creatinine ratio. By measuring the tiny amount of albumin and mathematically indexing it against the patient's creatinine excretion, you mathematically erase the massive variations caused by whether the patient drank a gallon of water or nothing at all that morning.
Because creatinine excretion happens at a remarkably constant rate throughout the day based on their muscle mass, the ratio normalizes the fluid volume variable perfectly.
We also monitor long-term damage via HbA1c, specifically measured via high-performance liquid chromatography, or HPLC. You need to understand the physical separation occurring inside that chromatography column. The lab lyses the patient's red blood cells using an acidic buffer.
At an acidic pH, normal hemoglobin A takes on a weak positive charge. The resin packed inside the HPLC column is negatively charged, so the hemoglobin A binds to it weakly. Now, consider glycated hemoglobin, HbA1c.
Because a bulky glucose molecule is physically and permanently attached to its N-terminus, that glucose actually masks some of the protein's native positive charge. Therefore, HbA1c has an even weaker positive charge than normal HbA.
Because it binds the weakest to the negative resin as the buffer flows through, HbA1c is washed out or eluted first. The analyzer measures that first peak. But that delicate charge mechanics system can be entirely disrupted by genetics.
What happens if a patient has an abnormal genetic hemoglobin variant, specifically hemoglobins S, D, E, or C? These are caused by single amino acid substitutions in the globin chain.
These specific substitutions happen to give the variant hemoglobin a higher net positive charge than normal hemoglobin A at that acidic pH. Because their positive charge is much stronger, they bind incredibly tightly to the column resin and are retained much longer.
They simply will not elute at the normal time unless the instrument is specifically programmed to perform an ionic strength adjustment in the mobile phase, flushing them off later. If the variant happens to co-elute and hide inside the A1C peak, it will falsely elevate the result.
And practically, because variants like hemoglobin S, sickle cell, drastically shorten the overall lifespan of the red blood cell from 120 days down to maybe 20 days, the hemoglobin doesn't live long enough to get glycated accurately. The entire A1C metric becomes clinically invalid for that patient.
Now, let's pivot from the glucose-carrying aspect of the red blood cell to the oxygen-carrying side. Iron studies in anemia. The board doesn't just want you to memorize a chart of highs and lows, they want you to understand the exact chronological sequence of iron depletion in classic iron deficiency anemia.
You have to know the timeline of the physiological collapse. The tissue stores drop first. The body is highly protective of its circulating iron, so at the first sign of a deficit, it begins quietly liquidating its reserves.
This means that serum ferritin, the primary intracellular storage protein, will fall steadily and significantly well before the actual serum iron levels drop. Once those ferritin warehouses are completely exhausted and empty, the diagnostic pattern becomes stark, immediate, and highly testable.
Serum iron finally drops to critically low levels. Ferritin is virtually undetectable. The liver, sensing this profound systemic starvation, desperately ramps up production of the transport protein, transferrin, trying to capture any stray molecule of iron it can find in the gut.
This overproduction causes the total iron binding capacity, or TIBC, to become highly elevated. But because you have this massive fleet of empty transport trucks and zero cargo to put in them, the transferrin saturation percentage crashes, often dropping below 10%.
Remember, TIBC is functionally a measurement of transferrin. You can mathematically estimate the TIBC directly by taking the measured serum transferrin mass and multiplying it by 1.4.
Which perfectly highlights why a physician ordering a standalone serum iron level at 9 a.m. is essentially wasting the lab's time. Serum iron fluctuates wildly with diurnal variation and diet. Without the context of the binding capacity and the storage levels, the single number is functionally useless.
This concept of requiring clinical context brings us directly into renal markers. Relying on a single renal value without understanding clearance is a catastrophic trap. Let's look at glomerular filtration rate.
The primary formula rule you need to recognize on site is the MDRD formula for estimated GFR. 186 times plasma creatinine to the negative 1.154 power times age to the negative 0.203.
The exam won't make you calculate negative exponents by hand, but they will absolutely test your understanding of the demographic adjustment factors tagged onto the end of that equation. Because the entire MDRD formula relies on plasma creatinine, and creatinine is a direct metabolic breakdown product of skeletal muscle mass.
So the formula must attempt to mathematically adjust for broad demographic averages in human muscle mass. Historically, you multiply the final calculation by 0.742 if the patient is female, accounting for statistically lower average muscle mass relative to men.
And you multiply by 1.21 if the patient is black, based on historical statistical cohorts from original studies. However, it is paramount to note from modern practice that the clinical and nephrology communities are rapidly abandoning these race-based coefficients because they are biologically flawed.
Moving heavily toward race-neutral formulas and entirely different biomarkers, which is exactly why the board exams will heavily test your knowledge of the superior alternative, cystatin C. What makes cystatin C so much better?
It is a 13 kilodalton protein that is produced at a remarkably constant, steady rate by absolutely all nucleated cells in the human body, not just muscle, every cell. It is small enough to be completely filtered by a healthy glomerulus, and then it is completely reabsorbed and enzymatically degraded by the proximal tubules.
It never enters the final urine. Why does the board love testing it? 2 reasons. First, its plasma levels rise rapidly the moment GFR falls below 90 milli per minute, making it significantly more sensitive for detecting early, silent renal disease than creatinine.
Because creatinine often won't flag until half the kidney function is already destroyed. Second, and most importantly, because it's produced by all cells and not just muscle tissue, its production rate is totally unaffected by a patient's diet, their gender, their age, or if they are an amputee with minimal muscle mass. It is a far purer marker of true filtration.
Speaking of the physical filtration mechanics, you must master the interpretation of the BUN to creatinine ratio. A normal healthy ratio hovers around 10-1 up to perhaps 20-1.
The classic exam scenario will present a patient with a BUN creatinine ratio that suddenly jumps to 30.1 or 40.1, featuring a highly elevated BUN, but a completely normal or only slightly elevated creatinine. You must instantly recognize this as the prerenal failure pattern.
So let's look at the fluid dynamics in the nephron to understand what causes that wild discrepancy. Prerenal means the problem is occurring before the kidney. The kidney tissue itself is perfectly healthy, but it is experiencing diminished blood flow.
Whether this drop in perfusion is caused by severe congestive heart failure, massive hemorrhage, or profound dehydration from a gastrointestinal bug, the circulatory insufficiency causes the actual pressure inside the glomerulus to drop. Because the pressure drops, the filtration rate slows down to a crawl.
The fluid is creeping agonizingly slowly through the proximal tubules. Now, the kidney tubules are physiologically designed to naturally reabsorb urea back into the blood. Because the fluid is moving so slowly, the tubule cells have excessive contact time to reabsorb massive amounts of urea back into the systemic circulation,
causing the serum BUN to spike aggressively. But creatinine is fundamentally different. It is not reabsorbed by the tubules, regardless of how slow the flow rate is. It passes straight through and is excreted. Therefore, the BUN skyrockets, while the plasma creatinine stays relatively stable, absolutely destroying the normal ratio.
When it comes to actually measuring that creatinine on the bench, labs almost universally use a variation of the Jaffe reaction. The board expects you to know the specific reagents involved. Saturated picric acid combined with sodium hydroxide.
When you mix them, you form alkaline picrate. Creatinine reacts with this alkaline picrate to form a distinct red-orange chromogen complex. It sounds like a simple colorimetric assay. You mix it, it turns orange, you measure the absorbance.
But the exam writers know that human serum is a chemical soup, and the ASCP board trap here is how you measure that color. The distractors will suggest you simply use an endpoint read, meaning you mix the reagents, walk away for 10 minutes, and measure the final static color.
If you do that, you will report a massively false result. Human serum is loaded with non-creatinine-reducing substances like ascorbic acid, massive amounts of glucose, and ketones that will also happily react with alkaline picrate to produce that exact same orange color.
So how do we isolate the true creatinine signal? We use kinetics. We measure the timed rate of product formation. It's a chemical race. The interference, like ascorbic acid or fast reactors, they spike the color in the first few seconds.
Other interferents, like large proteins, are very slow reactors. They don't really start contributing until minutes later. Creatinine reacts perfectly in the middle.
By programming the analyzer to ignore the first 20 seconds, measure the specific kinetic rate of color change over the next minute, and stop before the slow interference kick in, the machine effectively isolates the true, accurate creatinine signal.
We cannot leave the topic of renal and hepatic clearance without discussing the handling of ammonia. Ammonia is a highly toxic, neurotoxic waste product generated by the routine deamination of amino acids in the gut and tissues. A healthy liver rapidly clears it by converting it into harmless urea.
The pre-analytical collection strictness for ammonia is arguably the highest of any routine chemistry assay. You must draw in a specific anticoagulant, usually EDTA or heparin. More importantly, the phlebotomist must plunge that tube immediately into a slurry of ice water, and you must spin it and analyze it within minutes.
If you don't follow those rules, you fall right into the ASCP board trap. Massive false elevations. If blood stasis occurs during the actual draw, meaning the phlebotomist leaves the tourniquet on a struggling patient's arm for 3 minutes, or if the tube sits on the counter at room temperature unspun, the living red blood cells inside that tube will continue to actively metabolize.
They will generate ammonia in vitro. You will create a falsely critical result on a healthy patient. And clinically accurate ammonia levels are vital because they correlate tightly with hepatic coma, also known as hepatic encephalopathy.
Let's trace the physiology. When the cirrhotic liver fails to clear ammonia, it builds up in the blood and easily breaches the blood-brain barrier. Once inside the central nervous system, the excess ammonia forces a chemical reaction with the neurotransmitter glutamate, combining to form glutamine.
This reaction rapidly depletes the brain's vital glutamate supply, disrupting neurotransmission. But worse, the massive buildup of intracellular glutamine acts as an osmotic magnet. It pulls water into the astrocytes, causing massive cerebral edema, brain swelling, and leading directly to the coma.
Just as we track urea and ammonia to verify the functional clearance of the liver and kidneys, we track the liver's synthetic function, its physical production of specific proteins and lipids, to identify distinct, highly testable disease patterns.
Let's shift our focus to proteins and lipids. We begin with total protein measurement. You absolutely must differentiate between the theoretical reference method and the practical bench method, Kjeldahl versus Bayer.
Kjeldahl is the historical gold standard reference method. The fascinating thing is that it doesn't actually measure protein directly. It measures the total nitrogen content of the sample.
You take the serum, subject it to brutal acid digestion to break everything down to elemental components, and measure the liberated nitrogen. Because average human serum proteins consist of approximately 16% nitrogen by weight, you take that final nitrogen mass and multiply it by a conversion factor of 6.25 to mathematically estimate the total protein.
It is incredibly accurate, but incredibly hazardous, tedious, and completely impractical for a hospital lab. So the routine workhorse we all use is the Bayer method. Bayer doesn't care about nitrogen mass. It specifically measures the number of actual peptide bonds in the solution.
When you place serum in a highly alkaline solution, the peptide bonds coordinate with copper 2+ ions in the reagent to form a brilliant violet chelate complex. The more peptide bonds present, the more complex forms, and the deeper the violet color.
Once we have that total protein number, we often need to separate it to see the individual fractions using serum protein electrophoresis, or SEP. The board absolutely loves to test your visual recognition of SPEP densitometry patterns.
And the most heavily tested pattern is the beta-gamma bridge. On a normal, healthy SEP scan, you have distinct, sharp peaks for albumin, alpha-1, alpha-2, beta, and gamma globulins. Between the beta and gamma peaks, there is a distinct physical valley, an empty space on the gel where very few normal proteins migrate.
But the term bridge implies something is physically filling that gap. What exact protein is bridging the empty space on the gel between the beta and gamma peaks, and why is it there?
It is entirely driven by severe hepatic cirrhosis. In cirrhosis, the physical architecture of the liver is destroyed by fibrosis and scarring. Because the filtering sinusoids are blocked, the liver fails to clear routine antigens flowing up from the gut via the portal blood.
This chronic systemic exposure of gut antigens to the general circulation causes the patient's immune system to panic. It mounts a massive, prolonged polyclonal expansion of immunoglobulins, specifically overproducing IgA.
Now, structurally, IgA molecules happen to have an isoelectric point that naturally causes them to migrate right at the boundary line between the beta and gamma zones. When the immune system floods the plasma with massive amounts of IgA, the sheer volume of these molecules literally floods that specific physical region of the gel.
This completely obliterates the normal valley between the peaks, creating a continuous, visually distinct bridge of stained protein. Contrast this messy polyclonal bridge with the pattern of multiple myeloma.
Myeloma shows a restricted, highly narrow band of mobility, a sharp monolithic monoclonal spike, usually isolated deep within the gamma region. That spike represents a single rogue clone of cancerous plasma cells producing one specific identical antibody in massive quantities.
While SAPEP gives us the broad strokes of immune and hepatic protein synthesis, the board will also test you on hyperspecific, short-acting nutritional markers. Albumin is widely known, but it has a half-life of roughly 20 days.
If a patient stops eating today, their albumin won't drop significantly for weeks. That's useless for acute care. Therefore, prealbumin, also known scientifically as transthyretin, is the ultimate diagnostic marker for acute protein malnutrition.
Prealbumin has a rapid turnover rate, with a half-life of just 2 days. If an elderly patient is malnourished or a surgical patient is failing to thrive, their prealbumin levels will crash almost immediately, giving the dietitian real-time feedback.
A prealbumin level dropping below 11 milli-GDL is the hard clinical cutoff indicating severe, life-threatening nutritional deficiency. Now let's move to the lipid side of hepatic synthesis. The granddaddy reference method for total cholesterol is the Abel-Kendall method.
Like Kjeldahl, it is a multi-step, highly specific manual method. The first mandatory step is saponification. You add harsh potassium hydroxide to chemically hydrolyze the cholesterol esters, cleaving off their fatty acid tails to convert them all into free, unesterified cholesterol.
Then you use a solvent extraction step, usually with hexane, to physically pull the cholesterol away from the interfering protein matrix. Finally, the Lieberman-Burchard oxidation step reacts with the extracted cholesterol to produce a deep green-colored complex.
But nobody uses Abel-Kendall on the night shift. Routine hospital labs use automated enzymatic assays, and the enzymatic trap the board will absolutely test involves that esterase step. Routine liquid reagents use the enzyme cholesterol oxidase to break down cholesterol and generate hydrogen peroxide, which then drives a color reaction.
But here's the critical physical limitation. The cholesterol oxidase enzyme cannot utilize esterified cholesterol as a substrate. About 70% of the cholesterol circulating in a patient's plasma is esterified. It has a massive, bulky fatty acid tail attached to it.
The active binding site of the oxidase enzyme physically rejects that bulky tail. It won't fit. Therefore, a properly formulated routine lipid panel reagent must contain a secondary enzyme, cholesterol esterase, to pre-digest the sample and cleave off those tails first, yielding a pool of 100% free cholesterol for the oxidase to actually work on.
If that esterase component is omitted, expired, or defective, your machine will only measure the naturally free fraction, catastrophically underreporting the patient's total cholesterol by about 70%.
And you must know how to categorize the clinical risk factors associated with those lipid fractions once you measure them. For HDL, the good density lipoprotein that clears cholesterol from the tissues, the cutoffs are hard, fast, and testable.
An HDL value of strictly less than 40 milli-DL is universally classified as an independent major risk factor for early coronary artery disease. However, HDL has a unique protective scaling.
If the patient's HDL is exceptionally high, greater than or equal to 60 milli-GDL, it is considered so deeply cardioprotective that the physician will actually subtract one entire risk factor from the patient's overall cardiac risk profile algorithm.
Those enzymatic steps in the lipid panel are crucial, and the concept of an enzyme's active site perfectly sets up our next major subject block. The boards will heavily test your knowledge of theoretical enzyme kinetics and then ask you how we specifically use those kinetic principles to measure enzymes as circulating markers for cardiac and pancreatic necrosis.
Let's start with the absolute theoretical basics. The board loves to test the precise definition of zero-order kinetics. In zero-order kinetics, the mathematical rate of the reaction is completely independent of the substrate concentration. You can dump a bucket of substrate into the cuvette, and the reaction won't speed up by a single millisecond.
Why? Because the enzyme is physically saturated. Imagine a factory assembly line where you have 10 workers, the enzymes. If you put 10 car parts, the substrate on the belt, the workers are busy. If you put 1,000,000 car parts on the belt, the workers cannot work any faster.
Every single active site on every single enzyme molecule is occupied, constantly turning over product at maximum possible velocity. For zero-order kinetics to occur in a lab assay, the substrate concentration in your manufactured region must be formulated to be in massive excess.
Typically at least 10 times the Michaelis-Menten constant, or 10 times kilometers. Because the substrate is virtually unlimited, the only limiting factor determining the overall speed of the reaction is the physical amount of enzyme present in the patient's serum sample.
Therefore, by carefully measuring the speed of the color change over time, we are directly mathematically calculating the mass concentration of the patient's enzyme.
We apply those kinetic theories to cardiac markers, though modern emergency medicine has largely shifted to direct immunoassays for the definitive proteins, troponin, CKMB, and myoglobin. You need to know the physical, structural mechanics of troponin.
Cardiac troponin I and troponin T are not just random enzymes floating in the cell cytoplasm. They are deeply structural, regulatory polypeptides physically anchored into the sarcomere. They act as the molecular brakes, regulating the calcium-dependent sliding of the contractile proteins actin and myosin that allow the heart muscle to beat.
Because they are structurally integrated into the unique architecture of the cardiac muscle, they are the most tissue-specific markers for cardiac damage available. And the board will test your ability to apply these markers to highly specific, nuanced clinical scenarios like unstable angina.
Unstable angina is a condition characterized by severe cardiac ischemia. The heart is starving for oxygen, but there is no massive structural cell death yet. The sarcomeres are intact. Which marker spikes in unstable angina? It's troponin T.
While the vast majority of troponin T is anchored to the sarcomere, it maintains a very small, unbound cytosolic pool floating free in the cell's cytoplasm. Under severe ischemic stress, the cell membrane's permeability alters.
And that tiny free pool of troponin T can leak out of the cell and enter the bloodstream, triggering a positive lab result even before the structural sarcomere itself begins to disintegrate.
The major ASCP board trap regarding troponin involves how you interpret a massive infarction. A question might present a patient with a serial increase in troponin levels over 12 hours. The distractors will aggressively claim that this rising serial pattern exclusively, definitively indicates an acute ST elevation myocardial infarction or a classic STEMI heart attack.
That is false. A serial increase simply indicates active, ongoing cardiac muscle necrosis. The cells are dying and spilling their contents. That necrosis could absolutely be caused by an acute plaque rupture and a blood clot in the coronary artery. A classic heart attack.
But it could also be from severe viral myocarditis, a massive pulmonary embolism causing right heart strain, or damage from cardiotoxic chemotherapy drugs. Troponin only tells you the heart tissue is actively dying. It does not tell you if the plumbing is blocked.
Moving away from the heart, let's look at the pancreas. The board will routinely ask you to differentiate the clinical utility of amylase versus lipase in the diagnosis of acute pancreatitis. Both of these digestive enzymes will rise rapidly when the pancreatic acinar cells become inflamed and damaged.
But lipase is universally considered the vastly superior diagnostic marker. The physiological reason why comes down to the metabolic timeline and renal clearance. Amylase is a physically smaller molecule.
When the pancreas is damaged, amylase floods the blood early, peaking within 2 to 12 hours of the onset of abdominal pain. But because it is so small, it is rapidly filtered and cleared by the kidneys, dropping back to baseline normal levels very fast, often within 24 to 48 hours.
If a patient toughs it out at home and waits 2 days to go to the ER, their amylase might be completely normal, causing you to miss the diagnosis. Lipase is a larger, more complex molecule.
It peaks a bit later, around 24 hours. But because it is not cleared as efficiently, it remains abnormally elevated in the serum for a full week, providing a massive diagnostic window.
Furthermore, the kidney alters how it handles amylase during acute pancreatitis. The renal tubular reabsorption mechanism for amylase essentially fails, causing the amylase to creatinine clearance ratio to jump significantly.
Normally, this ratio is around 1% to 2%, but in acute pancreatitis, it skyrockets above 4%, sometimes even hitting 15%, because the kidneys are just dumping the amylase into the urine.
We spent time looking at enzymes that are released defensively or accidentally when an organ is damaged. Now we must pivot to the hormones that are actively, purposefully secreted to regulate those organs.
Understanding the concept of primary versus secondary organ failure is the paramount rule here. In endocrinology, you are never just looking at a value, you are evaluating a dynamic feedback loop.
Let's trace the feedback loop for calcium and the parathyroid hormone, or PTH, axis. The board loves to test the distinction between primary and secondary hyperparathyroidism.
In primary hyperparathyroidism, the primary defect is isolated entirely within the gland itself, usually a benign parathyroid adenoma, which is a tumor autonomously pumping out uncontrolled amounts of PTH. The lab pattern is distinct: high calcium, high PTH, and low phosphate.
The tumor secretes PTH. The PTH aggressively pulls calcium from the bone reservoir into the blood and simultaneously forces the kidneys to dump phosphate into the urine. In secondary hyperparathyroidism, the parathyroid gland itself is totally normal and healthy.
It is appropriately reacting to a systemic physiological failure elsewhere, usually chronic end-stage renal disease. The failing kidneys lose the ability to activate vitamin D. Without active vitamin D, the gut completely fails to absorb dietary calcium. The patient's blood calcium drops.
The normal parathyroid gland senses this drop and goes into overdrive, resulting in a lab pattern of low calcium triggering a massive reactive high PTH. But measuring that PTH accurately is an analytical minefield. You must thoroughly understand intact PTH assays.
Once the parathyroid gland releases the complete 84 amino acid PTH molecule into the bloodstream, it is almost immediately degraded by the liver and kidneys into various circulating fragments. N-terminal fragments, middle fragments, and C-terminal fragments.
Only the N-terminal fragment contains the specific shape required for active biological function at the bone and kidney receptors. The historical analytical problem was that assays using a single antibody might indiscriminately bind to the inactive C-terminal fragments.
In a patient with renal failure, those inactive fragments can't be cleared, so they accumulate massively in the blood. A single antibody assay would read these inactive fragments and give a falsely astronomical result. Modern clinical assays solve this by utilizing a two-site double antibody sandwich technique.
One highly specific antibody is anchored to the solid phase and binds exclusively to the N-terminal region. A second, labeled antibody, binds exclusively to the C-terminal region. The analyzer will only register a signal and produce a result if an entire whole intact molecule is physically present to bridge the gap between the two antibodies.
So let's apply that exact same logic of feedback loops to the adrenal axis, specifically differentiating Cushing's syndrome from Cushing's disease. The terminology is critical here. Cushing's syndrome is the broad umbrella term for hypercortisolism of any cause.
Whether it's from a tumor or just a patient taking high doses of prednisone for asthma. The most specific diagnostic endocrinology test used to pinpoint the exact internal source of the excess cortisol is the high-dose 8 mg dexamethasone suppression test.
No, wait, I'm confused here. If dexamethasone is just a synthetic steroid, why does the specific milligram dosage matter so much to the diagnosis? What exactly is the 8 mg high dose doing to the brain that the low dose isn't?
It's all about overwhelming the tumor's resistance. Dexamethasone acts as a massive negative feedback signal on the hypothalamus and the pituitary gland. It mimics cortisol, telling the brain, we have too much steroid, shut down production.
If you give a completely normal, healthy person a low dose of dexamethasone overnight, their healthy pituitary senses the steroid, appropriately shuts off ACTH production, and by morning, their adrenal cortisol output has plummeted. They are mathematically suppressed.
Now, consider a patient with a benign pituitary tumor that is slowly overproducing ACTH, which is the specific condition defined as Cushing's disease. That pituitary tumor is mutated. It is highly resistant to normal negative feedback.
It will completely ignore the low-dose dexamethasone, and morning cortisol will remain pathologically high. But if you hit that specific pituitary tumor with the high-dose 8 mg pharmaceutical hammer, you can finally overwhelm its resistance.
It will finally suppress, ACTH will drop, and cortisol will fall. Conversely, if the patient has an ectopic ACTH-producing tumor like a highly aggressive small cell lung cancer or a primary adrenal carcinoma, those malignant tumors are completely autonomous.
They don't have feedback receptors at all. They will not suppress, no matter how much high-dose dexamethasone you pump into the patient. The ASCP board trap regarding cortisol is the initial screening protocol. A distractor will suggest using a single-point random serum cortisol draw to screen a patient for Cushing's. Never do this.
Cortisol is not secreted in a steady stream. It is secreted in pulsatile bursts throughout the day, peaking in the early morning and dropping at night. Furthermore, it is deeply, instantly affected by physical and psychological stress.
A single blood draw is just a momentary snapshot that can easily misclassify a terrified, stressed patient in the ER as having Cushing's syndrome. To screen properly, you must always use a 24-hour urinary-free cortisol collection.
By collecting all the urine produced over a full 24-hour cycle, you mathematically capture the entire integrated area under the curve of the patient's daily cortisol production, completely eliminating the pulse variation and the acute stress spikes from the equation.
Endogenous hormones naturally have a half-life and highly regulated internal feedback loops to prevent runaway toxicity. But when we start introducing exogenous synthetic drugs into the body, those natural feedback loops don't exist.
We have to artificially step in and monitor the peaks and troughs of those drug levels to prevent catastrophic toxicity. This brings us directly to toxicology and therapeutic drug monitoring, or TDM. Let's start with the physiological hurdle every oral drug faces: hepatic first-pass metabolism.
The anatomical concept here is foundational. When a patient swallows an oral medication, it is absorbed through the highly vascularized walls of the intestines. But those intestinal capillaries do not drain into the general circulation.
They all converge into the portal vein, which delivers the blood directly to the liver before it ever reaches the heart or the systemic circulation. The liver acts as a brutal initial filter, heavily metabolizing, breaking down, and clearing a massive fraction of that oral drug on this first pass.
A classic pharmacological example is propranolol. A huge percentage of the oral dose is destroyed before it ever reaches the heart to lower the blood pressure. The ASCP board trap distractors will try to trick you by suggesting that intravenously administered drugs also suffer from first-pass metabolism.
They absolutely do not. 4V drugs are injected directly into the peripheral venous system, flowing straight to the right heart, completely bypassing the portal vein and the liver's initial filter.
Because they skip the liver, IV drugs follow a distinct biphasic or two-compartment elimination model, where the serum level spikes instantly and then falls extremely rapidly in the first phase as the drug distributes rapidly from the central blood compartment out into the peripheral tissue compartments.
Because oral and IV drugs behave so differently dynamically, clinical pharmacists rely on lab techs to tightly control their dosing using peak and trough adjustments. The golden unbreakable rule of TDM is that the trough level is always drawn immediately, usually within 30 minutes before the administration of the next scheduled dose, regardless of whether the drug is oral or IV.
You are measuring the absolute lowest concentration in the patient's system. Peak timing, however, is wildly variable and heavily dependent on the specific drug's absorption profile and the route of administration.
An IV aminoglycoside antibiotic might peak in the blood just 30 minutes after the infusion ends, while an oral dose of digoxin might take 8 full hours to slowly distribute and peak in the myocardial tissues. The board will test your understanding of this by giving you complex scenario analysis questions on dose adjustments.
Scenario 1. You measure a patient's drug levels, and the peak and trough are technically both within the therapeutic window, but the mathematical difference between them is incredibly small. The concentration curve is practically flat. What does this mean?
It means the drug is accumulating faster than the body can clear it. To fix a flat curve, you must increase the dose interval. You don't necessarily change the dose amount. You just wait longer between doses, changing it from every 8 hours to every 12 hours to give the sluggish kidneys more time to clear it.
Scenario 2. The peak level hits perfectly within the therapeutic range, but the trough level crashes way too low, falling below the minimum effective concentration hours before the next dose is due. The patient's liver and kidneys are clearing it too fast.
In this case, you must shorten the dose interval, giving the drug more frequently, say every 6 hours instead of every 8. But you keep the total daily dose exactly the same by lowering the specific milligram amount given at each administration.
To measure these drugs accurately, especially in complex forensic toxicology cases, the absolute gold standard reference method is GCMS gas chromatography mass spectrometry. You need to understand the distinct physical function of each half of that hybrid instrument.
The gas chromatography column performs the initial physical separation of the chemical soup. It boils the biological sample into a gas phase and uses an inert carrier gas to push it through a microscopically long, chemically coated capillary tube.
The compounds in the sample separate based on their unique boiling points and how tightly they physically interact with the specific coating inside the tube. But here is the limitation. The GC only tells you when a compound exits the tube, its specific retention time.
A retention time of 4.2 minutes is a great clue, but it does not definitively prove the chemical identity of the compound. That is where the mass spectrometer takes over. Think of GCMS like a police investigation.
The gas chromatography is like finding a specific shoe print at the crime scene. It tells you someone with a size 10 boot was there at a specific time, which narrows it down, but it's not enough for a conviction. The mass spec is the DNA test.
As the separated unknown compound exits the GC tube, it enters the mass spec, where it is violently blasted with a beam of high-energy electrons. This blast physically shatters the molecule into dozens of charged ion fragments.
The mass spec then acts as the ultimate mass filter, utilizing a complex quadrupole magnetic field to sort and measure those flying fragments based strictly on their mass-to-charge ratio.
Because every distinct chemical molecule physically shatters in a unique, highly reproducible, fingerprint-like pattern of fragments, the mass spec provides the definitive, mathematically absolute, legally defensible identification of the GOG.
And if your lab is utilizing GCMS to perform definitive confirmatory identification for employment or forensic drugs of abuse, or DAU testing, you must be borderline obsessed with pre-analytical sample adulteration.
Patients facing legal or occupational consequences will go to extreme lengths to beat a drug test. They will dilute the sample with toilet water, substitute it with synthetic urine they bought online, or add harsh chemical adulterants like bleach or glutaraldehyde to destroy the drug metabolites.
The board heavily tests your knowledge of specimen integrity and the strict legal criteria for rejecting a urine DAU sample at the collection site. The hard board rejection criteria are uncompromising.
First, reject the sample outright if the total volume provided is under 30 milliliters. That is simply insufficient volume to perform the primary screening assay, the confirmatory GCMS assay, and leave enough reserve for a legally mandated retest if the result is challenged in court.
Second, and most commonly tested, reject the sample based on temperature. The collection cup has a built-in temperature strip, and the collector must visually read it within 4 minutes of the patient handing the cup over.
The legally acceptable physiological range is between 90 degrees Fahrenheit and 100 degrees Fahrenheit. If the cup reads 85 degrees, the patient clearly brought in a concealed bottle of synthetic urine from outside.
If it reads 105 degrees, they strapped a chemical hand warmer to the hidden bottle and overheated it. In either case, the sample is immediately rejected, and a direct observation collection is usually mandated.
We use the incredible power of mass spec to definitively identify microscopic chemical toxins introduced from the outside. In the exact same way, modern oncology relies on highly specific, targeted molecular markers to definitively identify tumors growing on the inside, and more importantly, to determine their exact targeted therapy.
Let's explore tumor markers and companion diagnostics. The classic, most heavily tested example is prostate-specific antigen, or PSA. PSA circulates in the blood in two distinct physical forms.
The majority of it is bound to large carrier proteins, primarily alpha-1 antichymotrypsin. This is called complexed PSA. A smaller fraction floats entirely unbound. This is free PSA. The routine total PSA assay simply measures the sum of both.
The ASCP board trap here is the clinical interpretation of the free PSA percentage calculation. The distractor relies on flawed intuition. You might intuitively guess that rhode unbound free cancer cells produce unorganized free PSA. The reality is the exact physiological opposite.
Malignant prostate cancer cells actively produce a structurally altered form of PSA that is highly prone to rapidly binding with those carrier proteins. Therefore, as cancer progresses, the bound fraction skyrockets and the free fraction plummets.
A free PSA percentage that drops to less than 25% of the total PSA is a major, statistically significant high-risk factor for malignant disease. Conversely, benign prostatic hypertrophy, or BPH, which is just the normal non-cancerous enlargement of the prostate gland in older men, generally produces normal PSA that remains largely unbound, resulting in a reassuringly higher percentage of free PSA.
We see a similar requirement for measuring specific molecular subunits when we look at human chorionic gonadotropin, HCG. Everyone knows HCG is the standard pregnancy hormone, but the board focuses on its role as a critical tumor marker for aggressive testicular cancer.
Standard HCG is composed of an alpha subunit and a beta subunit linked together. However, highly mutated testicular and trophoblastic tumors often lose the sophisticated cellular machinery required to assemble the complete intact hormone.
Instead of assembling it, they aggressively secrete massive amounts of just the isolated beta subunit floating freely in the plasma without the alpha subunit attached.
Therefore, if you are utilizing the lab to monitor a male patient for testicular cancer recurrence post-surgery, your selected assay must be specifically designed and validated to measure both the intact whole HCG molecule and the free beta HCG subunits to achieve maximum diagnostic sensitivity.
If your lab uses a generic pregnancy assay that only recognizes the whole intact molecule, you will report a completely normal negative result while the tumor silently and aggressively metastasizes through the patient's lymphatic system.
This precise molecular targeting brings us to the absolute cutting edge of the board exams, companion diagnostics, specifically focusing on genetic mutations within the tumors themselves.
Wait, let me ask a structural question here. If the pathology department does a physical biopsy, looks under a microscope, and tells the oncologist the patient definitively has stage 3 colorectal cancer, why is the lab then required to run a massively expensive genetic sequencing panel on that specific tumor? We already know what organ the cancer is in.
Because knowing the anatomical organ of origin is no longer sufficient for modern treatment, the specific microscopic genetic mutation driving the tumor dictates the pharmacology of the drug. The classic board example is the KRAS gene.
KRAS is a res oncogene. Think of it as a molecular switch located just inside the cell membrane that tells the cell to divide and multiply.
In normal, unmutated cells, modern chemotherapy drugs called EGFR inhibitors like cetuximab can bind to the receptor on the outside of the cell, effectively blocking the signal, which turns off the internal KRAS switch and stops the cell from dividing. It's a highly effective targeted therapy.
But if a patient's colorectal tumor has a specific genetic mutation in the KRAS gene itself, that internal switch is physically broken and jammed permanently in the all-in position.
It doesn't matter how much expensive EGFR inhibitor drug you pour onto the outside of the cell receptor. The internal switch is bypassing the receptor entirely and continuously signaling the tumor to grow. Therefore, a KRAS mutated tumor is completely 100% resistant to EGFR inhibitors.
Testing the KRAS gene in the lab is called a companion diagnostic because the genetic test must accompany the drug prescription. It prevents the oncologist from administering a highly toxic, massively expensive, and completely ineffective therapy to a patient who will derive absolutely zero clinical benefit from it.
Now that we have covered the entire spectrum from physical optics to molecular genetics, it is time to execute case synthesis. Throughout this entire briefing, we have been looking at distinct, isolated silos of analytical information.
But the board writers will not test these concepts in clean isolation on the hardest, highest point questions. They are going to combine them into complex, multi-system, cascading patient cases. Let's look at the renal electrolyte TDM collision.
The clinical scenario is a 70-year-old male patient who is taking a highly toxic oral antiarrhythmic drug to control his heart rate. He contracts a severe gastrointestinal virus, suffers from 3 days of vomiting, becomes massively dehydrated, and subsequently goes into acute prerenal failure.
How do you recognize the prerenal failure on the lab printout? His BUN to creatinine ratio abruptly jumps from a normal 15.1 to an alarming 30.1, with a massive spike in BUN and a relatively stable creatinine. Okay, so the kidneys aren't getting enough blood flow. What is the immediate electrolyte impact of that prerenal failure?
Poor glomerular perfusion pressure means the fluid moving through the millions of nephrons is moving at an absolute crawl. This incredibly slow flow rate leads to the prolonged isosmotic equilibration of salt and water.
The struggling kidneys, sensing the severe dehydration and low blood pressure, desperately activate the renin-angiotensin-aldosterone system to reabsorb every single molecule of sodium they can find, attempting to raise the blood pressure. This causes a massive total body sodium excess.
But because water always passively follows sodium through the tubule membranes via osmosis, massive amounts of fluid water are retained alongside the salt. The patient rapidly transitions from dehydrated to grossly hypervolemic, swelling with fluid.
The sheer massive volume of retained water physically dilutes the circulating sodium pool. This means the patient paradoxically manifests on your morning chemistry panel with a severe dilutional hyponatremia. Their sodium concentration reads artificially low, even though their actual total body sodium mass is at record highs.
Giving this patient IV saline to fix the low sodium number would be a catastrophic clinical error. And while the fluid dynamics are failing, what is the TDM impact on his heart medication? Because his glomerular filtration clearance, measured functionally in milliliters per minute, has absolutely plummeted, the first-order linear elimination pathway of his antiarrhythmic drug is completely bottlenecked.
The drug cannot physically escape the blood to enter the urine. If the nursing staff on the floor continues to blindly administer his maintenance dose at the normal 8-hour interval, his steady-state drug levels will skyrocket exponentially into the lethal toxic range within a day.
The medical laboratory scientist must rapidly identify this declining GFR pattern on the basic metabolic panel, immediately notify the clinical pharmacy to aggressively lengthen the dose interval of the antiarrhythmic to prevent a catastrophic drug-induced lethal arrhythmia.
And simultaneously looking ahead at the cascade, you should be preparing the analyzer to run an intact PTH assay. Why do we need the intact PTH assay right now? Because as that kidney function continues to fail, the nephrons stop excreting dietary phosphate into the urine, and they completely stop activating vitamin D.
The serum calcium levels begin to crash, the toxic phosphate levels begin to spike, and the parathyroid gland responds to the chaos by dumping massive amounts of parathyroid hormone into the blood to compensate.
By understanding the timeline, you are anticipating and watching the inevitable, real-time physiological onset of secondary hyperparathyroidism hyperparathyroidism before the doctor even orders the test.
That is the ultimate takeaway. The expert summary here is that as a medical laboratory scientist, you aren't just a technician looking at a high BUN number flashing on a monitor. You are an essential diagnostician watching a systemic physiological cascade failure that bridges across 4 entirely different analytical benches in your laboratory.
And that wraps up our final technical briefing. We accomplished the mission today. We decoded the board's specific targeted distractors. We connected the raw mathematical physics of the instrumentation to the physiological organ-level failures of the patient, and we isolated the high-yield data you absolutely need to recall under pressure.
But before we sign off, I want to leave you with one final provocative concept to mull over. Think back to the pseudohyponatremia trap we discussed at the very beginning of the deep dive.
An indirect IS failed to give the correct life-saving sodium result purely because a massive lipid globule physically displaced the water in the plastic sample tube. It was a failure of spatial geometry, not a failure of analytical chemistry.
I want you to consider how many other heavily relied upon gold standard optical and chemical assays you run every single day that are secretly, quietly vulnerable to the actual physical geometry of the patient's plasma.
If a simple lipid globule can displace water and trick a computer, what is a massive, sticky monoclonal protein spike from a myeloma patient doing to the microscopic viscosity dynamics of your analyzer's automated pipetter? What is an invisible microscopic clot of fibrin doing to the delicate physics of light scatter inside your nephelometer?
The digital numbers that flash on your screen look absolute, confident, and precise, but they are only as good and only as true as the physical matrix they float in.
Keep questioning the matrix, keep attacking the distractors, and go crush the exam.